Good afternoon. Good afternoon. Thank you for coming to this session on weight management. I'm Kay Loria from the National Heart, Lung, and Blood Institute. And I'd like to introduce the first speaker, Catherine Kim. She's from San Francisco State University. She'll be talking, her title is In Touch, Impact and Lessons Learned from an mHealth Intervention for Overweight and Obese Youth.
Great, thank you. I'm very pleased to be here. Our project In Touch was one of 5 projects funded under the Robert Wood Johnson Foundation Project Health Design. So I'm going to tell you about our study, which was completed earlier this year. You will probably already know this, but childhood obesity obviously is on the increase. We've had significant issues with this over many years. But we did our project in San Francisco, where our rates for childhood obesity are much higher than the national average. So among San Francisco boys, we had 29%, and this is in 2008. Among San Francisco girls, 19%. So we had an additional issue in San Francisco we recognized locally, and that's why we wanted to do the intervention locally. Our project was born out of this recognition that health happens in real time, right? It's not the few minutes that you spend with a doctor a couple of times a year or once a year if you're a young person. You might only go into the doctor for the physical, for your sports team, or an acute episode. But you're really not working with your clinician on a daily basis to manage your health. Those decisions are happening as you go about the rest of activities in your daily life. And so we also recognize that in previous interventions where we tried to engage youth with, through the public hospital, San Francisco General, that we often couldn't ever get them to come in. So a previous study looking at cardiovascular risk among youth, they were required to come in 3 times during the study, at the beginning, 1 point in the middle, and then 3 months later. 30 participants were recruited. All of them came to the first visit, 2 came for the second, and none came for the final. And this is very typical. They think it sounds great, we'll do it, and then when the reality comes of coming back to a hospital, to a clinic, where they don't see the relevance to their own lives, they just don't have any interest in doing that. So we knew that's what we were really up against with our participants. So our study was a quasi-experimental test of whether and how observations of daily living could be collected, interpreted, and acted upon by both patients and their care teams to improve the management of overweight and obesity in youth. Observations of daily living, if you haven't heard that term, ODLs, are really the things that patients or individuals see in their daily lives. There can be thoughts, sensations, observations, activities that help them get a clue about what's going on with their health or their decision making. And this is a term that was coined by Project Health Design, which I mentioned is the project that we were funded under through Robert Wood Johnson Foundation. So the population we worked with was in San Francisco. They're low-income minority youth, so our participants were 13 to 24 years old. And we worked with them in 2 settings. The first was the Mission High School, which is a public high school in San Francisco in a heavily Latino neighborhood, where a large proportion of the students are on free and reduced lunch programs, so it's a low-income school. The second setting was our public hospital, San Francisco General Hospital, and we worked with the Pediatric Healthy Lifestyles Clinic and the Family Health Center's teen clinic there. So and I'm giving you the results of our first cohort, which was 34 participants, as I said, aged 13 to 24 years old. 50% were Latino, 21% African American, and the remainder were Asian Pacific Islander and Native American or multi-ethnic, self-identified as multi-ethnic. So it was an entirely minority population that was in our study. The actual study was the use of a self-tracking system we built with thecarrot.com, which is a private company. And over 6 months, they used these trackers, food, exercise, socializing, and mood. And they used it on an iPod, so there was no need for a smartphone or a data plan, which is very expensive. It was all done through free Wi-Fi that was accessible throughout the city or at the school. We had them track information and actually only required them to track for the first week. So we said, please do this for the first week so that we knew that they could actually use the application and that they weren't having issues with that. And then it was implemented within a health coaching program. So we had 2 health coaches who would work with them either at the school or in the clinic or meet them somewhere else that was convenient to them. So the health coaching was brought to wherever the participant wanted to meet with the health coach. And the health coach would look at the data they inputted, would help them to understand it, help them to identify goals and action plans if they were ready to do it. But the other important piece of the intervention was that it was based on motivational interviewing. So we didn't have a protocol that said you must come in, identify a goal, and work towards that goal. They came in and the coach said, you know, what are you concerned with? What are the things that are important to you? Is there something you want to work on? And if they weren't ready to say yes, then we didn't actually have them start. We gave them access to the technology, but we didn't say you have to start now. So it was only when the participant was ready to do something that then we asked them to actively engage. And they worked on this, the self-tracking and working with the health coach over a 6-month period. In addition to the data being presented to them via the iPod, they could actually see a daily journal on the iPod, so they could see everything they were entering. They could see it over time. But we also had a web portal. And the web portal allowed the participants to take all the data they were collecting and do ad hoc analysis. So they could do graphs, they could do charts, they could say, I want to look at my mood versus my food intake versus my activity levels. I want to see how much I'm socializing, you know, compared to my moods, and they could do ad hoc analysis on the web portal. We also wanted that data to be available to the care team. And our definition of care team comes from Tom Bodenheimer's work, who was a co-PI on this study, which was the physicians, the nurses, the social workers, the health workers, and the medical assistants. So it was a comprehensive care team. And we wanted the care team to also have access to this information so that they could use it as they prepared for clinical visits. And so part of our design process, though, was to ask our participants, what information do you want to have accessible to these others, to the members of the care team? What are you comfortable sharing? How do you want this to be used by them? And we learned some very important things. One, they said, actually, we don't care if they see all of it. We're fine with them seeing everything. It's what they say to us after they see it that's important. We don't want them to come back and judge us and, you know, to say, you're not doing something right, or, you know, why did you do this in a judgmental way? So they said, if they're being supportive and using the information to help me, I'm fine with them seeing everything. But then we asked the clinicians and the other care team members, what information do you think is important? What do you want to see, and how do you want to see it? And it was very prominently said to us in our focus groups, we don't want to see all the data. That's too much information. We don't know what to do with it all. We really have a few minutes to read the chart before we see the patient, and it has to be consumable by us in those few minutes. So they said, put it all on one page. We'd like to see what's happening most recently, so this previous week before the visit. And then we want a trend, say over the last 4 weeks, what's going on. And then a few key things, like from the text piece of the journal, what are the key things they're talking about? Right? What are the notes that they've said? Or what are the foods that they've most often recorded? So we just have a glimpse of what's most important to them. So we created this one-page summary report that was produced each week. And then the 4-week trending average was, you know, over the most recent 4 weeks. And that was delivered in 2 ways again. The first way was actually integrated with the electronic health record at the public hospital. So it actually became a clinical document in the electronic health record so that the staff at the hospital could bring it up along with all the other clinical data that they had. And then for the school, it was available through a web portal because the school does not actually maintain an EHR for its wellness center. And so they had nowhere to put the information. So it was available through a web portal. And the participant chose who got access to it. So we had their permission for each individual that had access to their information. So this is an example, and it is sample data because every time I've done this, people have said, is that real data? Are you being HIPAA compliant? It's not real data. It's something we made up. But that's an example of the report. So what are our results? This, as I said, was the first cohort of our study, so it was 34 participants who started. We did have a 30% attrition rate, so we had 24 participants actually complete the study. 35% of our participants showed depressive symptoms, so on a PHQ-2 screening of 3 or greater. There was no change in the PHQ scores from before the intervention to the after. We did use this, though, as a screening tool in order to identify anyone who had moderate symptoms was actually referred to a primary care physician or to the psychiatric social worker in the clinic in order to get treatment. We found 2 significant results. The first was waist circumference. So on average, they reduced their waist circumference by 1.2 inches. And patient activation level. So patient activation measure is a validated tool in adults and for several chronic illness conditions. It has not actually been validated in youth, but we went ahead and used it. And it's a measure of self-efficacy and confidence in self-management for health conditions. And so we measured pre and post, and we had an increase of 0.4 of a clinical level of patient activation increase. So that meant that through the intervention, they increased their self-efficacy and confidence that they could manage their health condition. So those were our two significant results. But we also learned quite a bit of other things from this study. It was really important to us as we designed this that we were engaging the participants throughout the design process. So we developed a youth advisory board, which was 10 members from a similar demographic, age, ethnicity, and socioeconomic status as the participants in our population, but they were not eligible. So they were either in college already at San Francisco State, or they were in the East Bay of the Bay Area, and our study was only in San Francisco. But we engaged 10 members of the population in our advisory board, and we worked with them from the very beginning. So we designed the intervention with them, we designed the application, we designed the coaching model. We asked them about how to do all the steps in our implementation plan. So we really had in-depth input from them throughout the process. And in fact, our youth advisory board were also the beta testers of our application once it was prototyped. We actually did a structured beta testing process with them before we went live with it for the study. One of the key things that we learned from our youth advisory board actually was really the design principle we used throughout the entire program. And we call that 5 clicks, 5 minutes. What they told us is you cannot make this burdensome. So there can't be any activity you ask me to do that requires more than 5 clicks or 5 touches. So it has to be that quick. And the second is, don't make me do anything that takes more than a total of 5 minutes a day. It's got to be something I can do quickly, build into my day, and not seem like an intrusion. And so we really worked with that throughout the design of the application and the intervention program itself. Our participants gave us great feedback on the program, and they said the technology was very useful and it was usable. It's very easy to use. They said they thought the reason it was so successful was that it made them mindful. Made them mindful of what they were doing on a minute-by-minute basis, and it made them mindful of what the impact it might have. And so that was a really important piece. The second was they felt the coaching was really critical. And you'd think they would just want to interact with the technology and not be bothered with an in-person visit, because that's what we'd learned from other studies. But actually they loved the health coaching. And many of them had visits with a health coach beyond what we had asked of them. We asked them once at the beginning, once at the end, and they chose to actually have more visits with a health coach, many of them every 2 weeks or once a month. We also learned from the care team what was helpful to them. So we were able to test the EHR integration for that summary report, and I'll have to say it wasn't probably the most successful part of our intervention, although we did get the reports in there on a batch basis. But they said that what was important was that report was a conversation starter. So rather than just saying to a young person, how's it been going? How have you been feeling? What you've been doing? And then have that person say, I don't know what I've been doing. They could look at this information and say, oh, I see that you've been doing this over the last week. Has it been working or not? What's going on? Do you have concerns about this? So it really helped them target a place to start that conversation that was meaningful to the patient. The third thing that was really critical, we think, for the success of this program was the partnership with the school. The participants from the school really found it very easy to be engaged in the entire program because they could drop by. They could come to the Wellness Center. They could come by, see the coach, and see the school nurse. They had a place where they felt like they could go talk about things. And it didn't require them to make some big effort to go to the hospital or go to a clinic or to a doctor's office. And they were at school most days. Sometimes they weren't there. But most days they were there. And so it became a really easy place for them to go to get help. And so we think that was a critical success factor in our project. And so finally, I would just like to acknowledge Robert Wood Johnson Foundation, who funded our program, and our partners with San Francisco General Hospital and Mission High School Wellness Center. And these are the other members of our team. Thank you.
We have time for one question. Sure. And could you introduce yourself?
My name is Aldo. I'm a pediatric gastroenterologist in El Paso. So great presentation and very important work. A few questions, actually three quick questions. If you can go over your inclusion, exclusion criteria, what your message was concerning sugar-sweetened beverages, and finally, these kids are often affected with fatty liver. Mm-hmm. I'm curious to know if your liver enzymes were followed throughout the course.
The third one we did not, because we were not doing clinical tests as part of our study, other than the weight and height measurements and those kinds of things. But inclusion criteria were BMI over 85th percentile for gender and age for the 18 and younger. And for the 18 and older, we did just 85th percentile. So it was overweight and obese. No significant mental health issues, so PHQ scores in the moderate range or below. If they were beyond that, they were excluded, although we didn't actually have any participants test in that. We did not give specific health education nutrition guidelines. It was very much an empowerment model where we asked them what they were interested in learning about and what they were interested in doing in their lives. If they came back and said, well, should I not be drinking sodas? We didn't say, you shouldn't be drinking sodas. We said, let's go find out. And so because they had the iPod, we would actually get on with the iPod with them and say, let's look up the information. What site should we go to? And we would work with them to find the information, and they would decide for themselves. So we did not give nutrition guidelines or specific messages around what they should and shouldn't do.
Thank you. We need to move on to the next speaker. Sorry. So the next speaker is Michael Lin from Johns Hopkins University. He'll be talking about the TRIM study, Tailored Rapid Interactive Mobile Message.
Thanks, Kay. So over the last couple of years, I've worked at the Johns Hopkins Weight Management Center with Dr. Cheskin. He's the director of the center, and he's here today, along with Zion from the team. I think I saw him walk in earlier. There he is. So we've developed a text message-based intervention called TRIM, Tailored Rapid Interactive Mobile Messaging. And our purpose was to develop a cost-effective, proven, and scalable intervention that can be deployed as a sustainable treatment option for obese patients. So we started by conducting a randomized control trial of the TRIM program among overweight and obese adults in Baltimore. And today we'd like to add to the conversation by presenting an overview of the study and some of the things we've learned through this trial so far. So we designed TRIM with the desire to reach underserved populations. So we started with an exclusively text message-based approach so that we can access the greatest number of patients today. And text messaging is a low-cost technology with potential to power easily scalable and low-cost and cost-effective intervention. I'll first spend a minute to describe the trial design before going into the details of the TRIM program. We're conducting a 12-month RCT with 2 arms, and we recruited 118 overweight and obese adults, or obese adults from churches in Baltimore, and randomized them individually to a control or the intervention arm. And in general, our recruitment process for this trial was much less stringent than the recruitment typically used for efficacy trials. Just as an example, we didn't screen for motivation level, and we did not do any adherence testing for study procedures. And we aimed to obtain results that might be closer to the results obtained in a real-world setting. It's also worth noting that we recruited participants from an underserved population that traditionally performs poorly in health behavior change interventions, and this also contrasts many weight loss studies. So moving on to the study groups. With the control arm, we try to capture the standard of care for obese patients. So at enrollment, participants came into our clinic and spent 20 minutes with a dietitian for a diet and exercise counseling session. And they developed a food and exercise plan and discussed goal setting and behavior change. We also gave each participant some educational material, as well as a pedometer. And then at month 3 and 6, the participants came back to the clinic for a brief counseling session, as well as additional educational materials. And at month 12, the participants returned for a final assessment. So that's the control group. And the intervention group received the same standard of care along with 6 months of TRIM text messages. So the TRIM participants received 3 to 4 messages a day for the first 6 months, and the text messages were designed to be semi-personalized and interactive. So for example, messages referred to participants by their first name And at enrollment, the participants selected 3 weight control goals from a list of 7 to work on throughout the TRIM program. And these goals span physical activity, diet, and behavioral triggers. The messages were also tailored to participants' daily schedule. For example, a message that asking about how many minutes a participant exercised that day would come 2 hours before they go to bed. So we're able to deliver a self-monitoring nudge at the end of the day. And a message about portion control might come 15 minutes before their lunchtime. And the last message each day is an interactive one, and that's where we ask the participant a question, and then we deliver tailored feedback based on their response. We designed the 6-month program overall with structure. So we're working on the goals in a specific pattern, and we built in a level of standardization across the goals. So regardless of which 3 goals you select, there were the same number of self-monitoring messages, for example, and the same core content, such as calorie balance. And just to illustrate some of the tailoring we do for individual TRIM participants, let's imagine me and my mom receiving the TRIM program. I wake up at 6, I have lunch at noon. And while I exercise regularly, I just love Twinkies. And I haven't completely outgrown my childhood habit of skipping the broccoli, and I have years of studying ahead of me. So my goals for TRIM might be to reduce my sugar intake, to have a more balanced diet, and to eat only when I'm hungry. My mom wakes up a little bit later and has lunch in the afternoon. And she gets less physical activity and tends to eat in larger portions, and she loves fried zucchinis. So my mom's 3 goals might be to reduce her fatty food consumption, to practice portion control, and to increase her physical activity. So during the program, I might get a message reminding me about vegetables around noontime, while my mom might get a message reminding her about portion control shortly before 2 o'clock. So we're receiving the message when each of us are about to make a decision on what we're going to eat for lunch. And we'll take a minute here just to walk through an example of an interactive message from the program. So for these messages, we ask the participant a question and have a number of prepared feedback messages that we deliver back to them, depending on the reply. And we define this logic beforehand so that we can automate this feedback process. So on the screen here is our weekly weight check message, and it asks me for my weight. I would step on the scale and send in the reading. And then TRIM responds based on my progress. So in this case, I lost a few pounds, and the feedback message tells me how many pounds I've taken off, and I received some positive feedback. In this case, if I gained weight, I would get a message telling me just that, and different feedback. So this is very simple logic, and we're able to take advantage of automation to deliver this interaction and engage the participants to both step on the scale and to receive tailored feedback to help them with their lifestyle changes. This is where I gain weight, excuse me. So we've captured our primary outcome data, which is the 6-month weight loss. And we'll share briefly some numbers from our preliminary analysis. So when we do a complete case analysis, which includes 42% of our participants, we find that the TRIM group achieved more weight loss than the standard care group, with 8 pounds on average compared to 1.3. And the TRIM group also achieved a greater percent body weight loss of 3.7 compared to 0.6. We've also started analyzing participant engagement with TRIM by looking at the percentage of days in which participants responded to that daily interactive message that comes at the end of the day. And so far we found a mean engagement of 60%. So on average, participants are responding to these messages more than half the time. And we also found that engagement with these interactive messages was a strong predictor of weight loss. Each additional percentage of engagement predicted a quarter-pound additional weight loss at 6 months. And the final results from this study will be available next spring. We have 12-month follow-up scheduled through January. And participant feedback for the TRIM program was quite positive. Our 6-month survey indicates an average overall satisfaction of 4.4 on a 5-point scale. And here's some specific feedback as well. We received suggestions from participants for areas of improvement. And In this case, we started with a very simple and standardized approach, and we limited the number of variables in this intervention and to run this baseline study. And naturally, we also limited what we offered to participants, and we saw that some participants wanted more resources. And we're in the process of dissecting this intervention and to better understand the value of each component and the areas that were lacking. So we also received, overall, we received substantially positive feedback from the participants in the bottom two quotes here. And we were really encouraged and even surprised by how positive the feedback was for an automated system. And the quote at the very bottom is from one of our participants who likes receiving trim messages more than having a human friend. And this is just to say that an automated low-touch approach can clearly help some patients. And we definitely realize that there isn't a one-size-fits-all solution. And we know that there's patients for whom this approach just won't work for, and we saw that in the study. So our goal is to better understand who benefits from trim and why it doesn't work for some individuals, and how we can predict whether or not someone will benefit from trim. And our study has limitations. The duration of the trim program was only 6 months, and our study population was recruited exclusively from Baltimore, all African American and an underserved group. And the trial had low rates of follow-up occurring within our protocol-defined 6-month window, and this resulted in an underpowered study. And it's worth noting that 80% of the participants came back for the intended 6-month follow-up visit, but there were challenges in scheduling the follow-up visits during clinic hours and challenges in participants' transportation to the clinic, lots of rescheduling, and we didn't adequately anticipate these issues, so this led to a lot of the 6-month follow-ups occurring past the defined window. So the results of this small pilot study supports the use of carefully designed and personalized automated programs that, to help tackle obesity. And for the participants that returned for their 6-month follow-up visit on time, are entirely automated programs. So this program requires no personnel effort after beyond enrollment, and it resulted in significantly more weight loss when added to standard care. So with our low intensity and non-intrusive approach, the magnitude of that effect size is noteworthy. And we also observed encouragingly high levels of satisfaction and engagement with the system. So all of this suggests that trim can help some fraction of overweight or obese patients lose weight. And in summary, trim's low cost, its reach, because there's no smartphone required, and its scalability supports its potential as a tool to help address obesity. And we see trim being integrated into existing strategies for addressing obesity. We also see it implemented as a standalone intervention. And we're further developing trim in duration, degree of tailoring, and sophistication. And we're always looking for collaborators interested in furthering this research. We'd like to speak with clinicians interested in taking trim beyond the research setting into a clinic and work with various patient populations. I want to acknowledge the McKesson Foundation and our research team for making this research possible. Please feel free to contact me or Dr. Cheskin. We'd love to hear your thoughts on what we're doing, how we can do it better, and how we might be able to collaborate. Thanks. I'll take any questions.
Are there questions for Michael?
Hi, thank you. I have a couple questions, actually. One is, what actual system did you use to automate? Like, was it Mobile Commons? Was it a free internet system? Like, what did you actually use? Mm-hmm. And second of all, I'm curious about your low-cost conclusion, because is it, so when you say automated, you still had to tailor a certain number of messages, and then what happened if a patient sent a question to you? Did it just go into the ether? Was there no way for them to... So it wasn't two-way, that way interactive. It was just interactive, you mean, before you got to the tailoring, and then you sat down and tailored messages, and then It was all automated after that?
Yeah, so once the 3 goals were selected, the content program was created.
Okay.
And each day, 2 of the messages were only one way. And if a participant responded to that one, they would get the default response of this is an automated system. No one's monitoring this. If you have any need to reach out, counselor or 911 for emergencies. But the one at night was the one where we actually asked them a question.
And then,
And then
what was the system you used?
we contracted a company to build it out for us once we defined the
So,
specifications.
and I assume that was not low cost.
That was not low cost.
But following on that, so now that you have it, can it actually be transported to a primary care setting without any additional cost?
Right. So that's where we're exploring right now, and trying to make sure that we have a system that can be scalable beyond this current intervention.
Great. Thank you. Oh, okay.
That 40% that fell off, 60% is a great number to get people through a program like that. And any analytics on that 40% that fell off? Any drivers about why they fell off the program?
So I think it's actually the other way around.
The 40% that fell off, right?
60.
60%.
So they just they didn't come in time. That's sort of what it is. And we're in the process of doing the data analysis for that. It's going to be interesting to figure out how to analyze that, because that's a lot of missing data. So we'll just look out for the data, the final outcome in, I guess, spring.
Without formal interventions of this kind, people get frustrated. So people who drop out, I can guarantee you they were not doing great in education or having some losing weight.
Mhm.
They get frustrated, they ignore it and stop.
Right. Thank you.
Thank you. Our next speaker is Misbah Mohammed from Partners Healthcare. Her title is Using Mobile Technology to Promote Healthy Behaviors in Teens.
Good afternoon, everyone. Thank you. It's exciting to be here. Here we are at the mHealth Summit, where the center of focus is on technology and using health. Sorry, technical difficulties. All right. In parts of Boston Public Schools and several schools nationwide, technology is not readily available. Imagine being a student in a classroom with resources that are limited, not even high-speed internet. Show of hands, how many in this audience would think it would be a best idea to implement a technology program in this type of setting with resources that are so limited? One of the schools we piloted our health program with, Byfield Elementary, located in low-income and unsafe neighborhood of Boston, was built even before wired for electricity, cold, or heating, and had no gym or cafeteria. What makes the work we do at the Center for Connected Health so unique is that we facilitate the adoption of connected health, regardless of what the infrastructure may present. We make it hybrid. We make it happen. We're the hybrid of making it happen. We went into these underserved schools. Schools and successfully implemented a health program by using simple, inexpensive, and easy-to-use technology, customized to fit the population and their needs. Our technologies allow users to measure something about themselves and feed it back to them in a potentially relevant way that can motivate them into a healthier state. One of our focus at the Center for Connected Health is to facilitate the adoption of connected health in the area of health and wellness. And one of the biggest challenges we face in this nation is obesity, as Kim had mentioned earlier. The obesity rate among youth, the overweight and obesity rate among youth is increasing at a high rate. As you can see from this graph, 28% of youth are overweight or obese, and that puts them at an increased risk of developing cardiovascular disease. As I mentioned earlier, some of the schools we worked with don't have the infrastructure. They don't have playgrounds. They don't have gyms to promote and encourage activity. And the one way we know to combat obesity is through physical activity. So do you know how many students don't attend physical education class? A recent study by the CDC mentioned that an alarming 69% of high school students don't attend physical education class. A lot of these students just sit and watch, more than 32% watch television for more than 3 hours on a daily basis. So one of the goals for Connected Health is to instill in these youths the importance of physical activity and get them up and moving. So I'm going to go ahead and show you one of our programs and briefly talk about that. One of our programs, Step It Up, was launched in March 2011. It was initially launched to 200 students at 2 schools in the Boston public area, and this year we expanded it to 6 schools, reaching 400 students. The goal of this health promotion program is to encourage students to be active, raise awareness about their current activity levels, and provide nutrition education. As part of this program, each student receives a simple pedometer, simple, very inexpensive pedometer that allows them to track their step count activity in minutes. And the way we kept them engaged in this program was through competition. So students were competing against classrooms to see who can get across America the fastest. You can see their graph right there. And the data on the pedometer was uploaded automatically when a student walked by a computer in the classroom. So the data is uploaded. And every Friday, like what kept them hooked onto the program was that every Friday students looked forward to receiving a weekly progress report that detailed the number of steps they've walked, how active they were, and like which group was winning. So and they also received information on nutrition as well. What also kept them engaged in the program was the fact that they were being incentivized too. So if they achieved like a weekly goal, if they were wearing the pedometer on a daily basis, they received charm bracelets, which you see right there, or like simple shoelaces. So something very cheap and inexpensive, but really kept kids motivated and engaged in this program. So with these young kids, it was very easy to get them excited and motivated through team competition. But what we've learned at the Center for Connected Health is that one size does not fit all. And it's something that Michael had also mentioned, that we can't give everyone the same type of text messages. We can't incentivize people the same way. Everyone reacts differently. So there are various mechanisms to engage and empower individuals to promote physical activity. Feedback loop is obviously very important. We know that everyone does not respond similarly, and different people require different mechanisms to engage. So at the Center for Connected Health, we collect data through simple devices like this, and feed it back to people in a potentially relevant way that can motivate them into a healthier state. The gap between feedback and action can be enhanced by motivational techniques. So as I mentioned in the Step It Up program, we had competition, we had incentives, we had all sorts of things that got them excited. And let me show you how successful those techniques were in Step It Up. So I have a couple slides that demonstrate the results. So one of the things that we were trying to see in Step It Up was, did activity increase over time? Were kids getting more steps, the ability to see their steps? So let's say I walked 3,000 steps today. What could I have done tomorrow to get more steps? So did we see an increase in activity among these children? So from this graph, we see that activity steadily increases over time, but we also see a decrease during week 7 through 9. In a minute, I'll show you why. But so the increase in step count was an interesting outcome, but we also wanted to see what the engagement level was. Were students engaged or were they not? In the last slide, we saw that there was a decrease in step count during week 8, and that was during vacation week. So engagement with the pedometers went down because the kids were not uploading their data, because as I had mentioned, that kids have to walk by a computer hub in order for their data to upload. So we saw a downward spike in activity during week 8, and it's because kids were out, they were out on vacation. But overall, you see that throughout the 10-week program, the percentage of students wearing their pedometer is fairly consistent. And like kids, they have a tendency to forget their lunch money. They have a tendency to forget their pencil. So it's really interesting to see that 97% of the students are still wearing their pedometer during week 9. So they're still engaged in the program. And yes, it's the technology, but there are other aspects that are keeping them engaged. The fact that they're receiving incentives, the fact that they're competing, it's all that feedback loop that's still making them wear their pedometer even until week 9. So this was very successful among elementary students. But though as the kids get older, it's harder to engage them in this type of program model. Because as I mentioned, we're all motivated by different things. So the Step It Up program was met with huge success. But now we want to take it a step further, take the lessons we've learned and employ it in a different setting to a different population. So we want to employ this program among high school students. And the first step in understanding the needs and preferences of this group was to conduct a focus group session to see what would engage high school students. Would they want to receive paper reports weekly as a feedback mechanism? Would they want charm bracelets? What we learned from these ninth graders is that they text heavily. we learned that on average they text about 300 text messages a day, and this is how they want to be engaged in a program. So these folks are connected to their phone. They sleep with it under their pillow, or sometimes fall asleep with it in their hand. So it's a way to keep them, get them engaged into the program. So this coming January, we're launching a 10-week pilot study among 30 high school students at the Massachusetts General Youth Scholar Program. And the purpose of this study is to engage high school students in the program, increase and sustain their levels of physical activity, and understand the role of team competition in promoting healthy behavior. So these 30 students will be grouped into 2 teams with 15 students each on each team. And they'll be split into these 2 teams based on their activity level during week 1. And then throughout the program, they'll be competing as a way to leverage social networks through teamwork. And then every week, they'll receive points based on their engagement and activity and work towards a grand prize towards the end. And the feedback mechanism we're using here is text messaging. So these kids will receive up to 5 text messages on a weekly basis. And those text messages are designed to motivate and educate and empower them to be physically active. And they'll also receive messages based on their activity level and how the teams are doing throughout that program. So this is a program that will start in January, so look forward to the results. So as we see, we can use simple technology, including like sensors, mobile phones, can be very effective in creating behavior change, even in resource-limited settings. We envision that mobile will change people's lives in a meaningful way, and mobile technology will get adopted no matter what the infrastructure may present. Simple technology can be the solution. So I just want to acknowledge some of my team members. Kamal Jitwani, who will be the PI in the upcoming research study that we're launching in January. Rob Devesi, who does most of our technical operations at the Center for Connected Health. And we have a behavioral psychologist on our team who helps with designing the text messages and tailoring them to the population, as well as Kinley and Joseph Kaviter. I'll be happy to take any questions.
Hi, Ivor Horn, Children's National Medical Center here in Washington, D.C. Great presentation. Thank you very much. I had 2 questions for you. My first question was related to the structure of the program within the school system and how much the teacher was involved in that process and getting the kids engaged in the process and engaged in the program. So that's my first question. My second question has to do with the adolescent program that you're starting and what's the demographic of that population, and also what's the demographic of the focus group population that you guys did.
Okay, so to your first question, in terms of like how involved are the teachers, so we have a staff at the Center for Connected Health that was heavily involved in terms of getting the program started and up and running. So we went to each of the schools, distributed to the pedometers, and got the students up and running. And the great thing about this program was that the teachers were also part of it, so the teachers were wearing pedometers as well. So so there wasn't much work on the part of the teacher, because like the kids got their pedometers, and then they were wearing their pedometers. They saw the teacher was wearing it, so they were starting to wear it as well. The only involvement in terms of like what the teacher had to do was pretty much just distribute the weekly reports to the students, and it had no interference on like what the class was doing or what the class structure or anything. It kind of built a sense of community as well. Just giving these pedometers to kids, it built a sense of community within the school as well, raised awareness about activity, and things like that. And then to your second question, in terms of the demographics for the second group, it's predominantly Caucasian. So the focus group was for about 15 students, and it's predominantly Caucasian.
And for your recruitment for your next study, do you guys have any demographic requirements or for that study?
So the study we're going to launch in January.
Right,
So
right.
we already have the students selected, and they're 9th grade students. They're predominantly Caucasian from the Massachusetts General Hospital Youth Scholar Program.
Okay, thank you.
Any other questions?
Thank you.
Thank you.
Our last speaker is Bree Turner-McGreevy from the University of South Carolina, and the title is, "Are We Sure That Mobile Health is Really Mobile?"
So I'm going to talk about 2 mobile health studies that I've done and look at the way people access the information as part of the study. So I'll talk a little bit about what we think mobile really means, and then talk about the devices, activities, and locations of 2 mobile health weight loss trials and some future directions. So when we think of mobile, particularly around our weight loss interventions, we think of it as the ability of our study participants to take the intervention wherever they want. They can be doing physical activity, they can walk, they can run, and they can self-monitor their behaviors, physical activity, and diet on the go. And it implies a certain amount of freedom when we think of mobile, and it may be preferred to other traditional methods we use to deliver weight loss interventions, such as being sedentary in a group intervention, with face-to-face, or sitting at a desktop computer with traditional wired delivery methods. And this is, not surprising to this group with these definitions, but when we think of mobile, it really comes down to the difference in network access method, with wireless standing in for things like our mobile phones and tablets, and having the ability that it can travel through time and space with our participants, whereas wired refers to a traditional desktop access method and implies that our participants are tethered to a device and therefore more sedentary. So despite these assumptions that we think that mobile delivery methods would be more preferred over traditional methods, little's known about how our participants are actually using our interventions, using mobile or traditional methods as part of weight loss interventions. So the 2 studies I'm going to talk about are a Pounds Off Digitally Study 1 and 2. The first one was done in 2008, and it was to determine if we could even remotely deliver a weight loss intervention. And this was a 3-month trial among overweight adults, using podcasting to deliver a behavioral weight loss intervention. In 2011, we did Pod Study 2, where we enhanced and lengthened the intervention out to 6 months, and we looked to see if we could add some additional mobile intervention components, such as self-monitoring diet, physical activity, and also providing social support via Twitter. And to highlight here, both studies required participants to have a mobile device to enter the study, and they were trained on how to use their mobile device to access the study components. So in Pod Study 1, everyone had an MP3 player. This was before smartphones, so this was mostly an iPod type crowd. And overweight participants were randomly assigned to either receive our enhanced theory-based intervention that we developed, having those components there listed, or a control podcast that we found to be the best available free weight loss podcast available online. Participants in the study were mostly white females in their late 30s. And what we found is our enhanced theory-based podcast produced greater weight losses than the control podcast, about 6 pounds at 3 months, and that corresponded with similar decreases in BMI. So in Pod Study 2, we took that weight loss podcast that we developed, lengthened it to 6 months, and participants were either randomized to receive a 6-month podcasting intervention, or they were receiving 6 months podcasting intervention, plus they downloaded an app to self-monitor their diet and physical activity, and they also received group and moderator support via Twitter. Again, mostly white females in the study, this time in their early 40s. So participants all followed one another on Twitter, and group study counselors would post 2 messages a day reinforcing the messages that were discussed via the podcast. All participants downloaded a mobile diet and physical activity app to track their dietary intake and their activity. And what we found is there was no difference between the groups in terms of weight loss, so the addition of these mobile components did not translate into additional weight loss, so there was no difference at 3 or 6 months between the podcast group and the mobile group. So that led us to sort of take a step back and say, okay, what was really going on in these groups? And the first thing we wanted to look at is the podcast. And so we combined Pod Study 1 and 2 participants for 174 participants and looked at 3-month outcomes. And the first thing we did is we asked participants in both studies, where were you accessing the podcasts? And what we found is that the majority of participants were accessing the podcasts at home, with 20% accessing them at work. So really 25% required a mobile device. They were either in the car or at the gym or traveling. We also asked participants what they were doing. Were they active? Were they mobile while they were listening to the podcasts? And we found that the majority of the time participants were sedentary when they were listening to the podcast. They were either sitting at a desk, sitting at home or eating. So 66% were really doing sedentary behaviors that didn't require mobile access. We also asked participants in both studies what devices they were using to download the podcasts. And again, despite us really promoting the use of mobile devices to download the podcast, the majority in both studies were reporting that they listened to the podcast on their desktop computer, 53% in Pod Study 1, and 57% used the computer in Pod Study 2. And we had objective download data as part of Pod Study 2 where we could actually see what devices they were using. And so this is not self-report, this is actually what they were doing. And again, we see about 50-50, 50% coming from a wired method for download and 51% coming from mobile. So I had this vision of people being active and out on the go, wearing their iPod, getting activity. And what I ended up getting was people sitting there tethered to their computer listening to the podcast. So I figured maybe that's something about podcasts. So then we looked at Twitter and saw how people were accessing Twitter as part of the study. And again, this is objective data. We could see where the Twitter messages were coming from. And in this study where participants were accessing Twitter, about 45% were using a Twitter website, only 33% were using an app, and we had everyone download the Twitter app and we trained them on how to use it. 22% were coming from a Twitter dashboard tool like Hootsuite or TweetDeck. That we weren't sure if that was mobile or not. It could be either or. So again, about 50-50 coming from mobile and not mobile. We did see some use of mobile with dietary self-monitoring. The Podcast Plus Mobile group in Pod Study 2 was encouraged to use a mobile app. So 62% did choose to use a mobile app to self-monitor their diet, whereas 38% used either traditional paper journal recording methods or websites. The podcast-only group was told to use paper journal methods only, but 33% decided they'd rather use a mobile app, and 67% used either paper or web methods. Physical activity, we also saw about 71% in the Podcast Plus Mobile group using a mobile app to track physical activity, which they were encouraged to do. In the podcast-only group, we're told to only use paper recording methods again, and 43% chose a mobile app, even though they were encouraged to use other methods. So going back to the podcast, I was interested in seeing, well, did the people who accessed it in a mobile way, were they more likely to lose more weight? And this is combining both Pod Studies 1 and 2, 3-month outcome, and adjusting for demographics. Use of a mobile device to access the podcast was not associated with greater percent weight loss or greater number of podcasts downloaded. So if you used a mobile device, you didn't lose more weight and you didn't download more podcasts. What we did see is that the number of reported podcasts downloaded was related to percent weight loss. So it didn't matter how you accessed the podcasts, it just mattered that you did access them. So several limitations as part of the study. Study 1 and 2 were with participants from a very narrow range of ages, gender, mostly women, ethnicities, mostly white. The studies took place in 2008 and 2011. Smartphones were really gaining popularity then. So we may see different results if we had different demographic groups or conducted the studies now. I'll say I wasn't able to add this in because we just got 3-month outcomes on a weight loss study I'm doing now. It's all remotely delivered, but not supposed to be mobile. It's email, tailored email newsletters, and Facebook. Participants didn't have to have a smartphone to enter. It wasn't a requirement. And we asked them at 3 months, how did you primarily access the study materials, Facebook, search for health information? 89% said mostly on their mobile devices. Even reading these little newsletters, they're going through and using their mobile devices. This is 18 to 35-year-olds, 50% African American, 50% college educated. So different demographics, different time. So I think we're going to see, as a result, this is all going to be shifting more and more to mobile, no matter what. But it could be that listening to podcasts, for example, is something that you like to do while you're multitasking. You're at work, you're at your computer, you're typing, and you want to listen to it, or you're checking your email at home. So that may have been what was driving that. And it may be that screen size is an issue as well, particularly if you're self-monitoring your diet and you're trying to read these charts, that it may have been easier to do that on a larger screen. So in conclusion, while participants in our 2 mobile health studies were provided with mobile means to receive weight loss information and receive social support and self-monitored diet and physical activity, many chose non-mobile means to do that. And it's possible that we need to provide multiple platforms for people to provide them with information versus focusing on mobile only. But future studies, I think, should examine why people choose wired over wireless, and in the reverse, why are people choosing mobile methods when we're trying to push more wired methods. And I think one of the themes that we've been talking about today is sort of the issue of engagement, and some people really engage with a certain type of delivery method. How can we figure that out before they even start the study, and then provide them with a text messaging intervention if that's what would work for them, podcasting if that's going to work for them? How can we do that at the beginning versus this one-size-fits-all kind of approach? That's it. Any questions?
Hello, Aaron Steele with the Department of Veterans Affairs. Just curious on the self-monitoring of diet, did they have a food database or was it entered from the calories listing on the food?
So they used Fat Secret calorie counting app, and it was because it was free and available. They had to have a BlackBerry, an iPhone, or an Android-based phone to enter the study, and that was available on all 3 platforms. But it allowed barcode scanning of foods, and it had a food database, and you could sort of enter your favorite foods in. So the idea was that it would make it much easier than sitting with a calorie book and looking up every calorie amount and then calculating it by hand.
Thank you.
So how old were the participants again in the pod and pod 2?
The first one, they were in their late 30s and early 40s in the second one.
Mm-hmm.
And so many of our participants brought their kids in to help them learn how to use this. So they'd bring their kids and they'd be like, you tell me how to do this. And, you know, the thought is those kids are going to be our next adult participants in these studies. So they're familiar with this. So, you know, I think we'll see a shift there.
Right. Looks like one more question. Can I ask the other speakers to come up? We have some time to talk.
I'm Dr. Lewis Wilson. I'm a nutritionist. We've known for many years that paper works. So did your patients that did not use devices have paper alternative? Is that what was happening? Because there wasn't an additional effect on mobile device, and they simply because paper works, and paper is mobile,
Right.
To some extent.
Right, exactly.
So
yes.
I mean, the records, we've known for many years that works extremely well. All you're doing is trading platforms. Can you comment on that?
Right. We did give the podcast-only group the Calorie King book and food records to keep track. We did see in a sub-analysis that those who use mobile devices, when we looked at their 24 diet recalls, consumed fewer calories, but we didn't see a difference in weight loss. So, the idea is that, food records, you have to actually add everything up, and the idea of this barcode scanning, maybe it would make it easier. We didn't really see that having the effect that we were hoping.
But again, that could be age, right?
Yes.
Yeah. So we have some extra time, and I thought we could talk a little bit about, maybe what we've learned from each other and where we think the field should go. It sounds like there's some simple text messages that seem to work, but maybe aren't quite ready for dissemination. But I think that's our goal, is to get tools out there that really are very effective. And I'm wondering if each of you could talk a little bit about where you think we should go next.
Sure, I'll start. I will also just mention that our application is available on the iTunes store. It's thecarrot.com. Was one of the reasons why we work with the private companies, because we wanted dissemination and commercialization as quickly as possible. So everything that was developed is available to the public for free. And I'll be demoing it at the NIH Pavilion tomorrow at 2:45 if you want to come see the portal and the application. But I think especially what we learned was that, and I didn't present this data, but our participants said that the benefit of the application without coaching, or coaching without the application, what they said was that it really needed to be both, and that one without the other would not have been effective, whichever way you did it. And I think that really drove home to us that It's the technology design and the intervention design really have to be linked together. You have to understand the behavior change model that you're trying to use that drives how you engage people and how you encourage them to make the changes that they want to make. And if the technology was not designed with the same purpose in mind, then you have a disconnect and it doesn't work as well together. So I think an area that I'm particularly interested in is really understanding the consumer engagement from the beginning of a technology intervention and long enough to actually have a sustainable change. And how you maintain that engagement over time is really important.
I think, going back to what she said, I think technology is not the intervention, it's how you package it. So what are the feedback mechanisms there? How are we going to engage this population? Is it through competition, incentives? And then you deliver that through technology. But technology is not the intervention that we're looking at. It's all the other things that are around it that can keep kids engaged or youths engaged into a program.
So I want to be a primary care physician, and I think, so it's really important for me, any research I do, to have the translation into the clinic, in the clinical setting in mind. And so we try to really take that approach with this study. And the question that was brought up about the cost of the technology, it really was a problem. It was a big hurdle that we had to jump through. We had issues finding somebody to build that for us within the budget that we had. And also, by the time we found somebody to do that, it took several months beyond our anticipated or our hopeful launch date. So I guess, and then now we want to make sure that we have in mind how we want to broadcast this beyond the research setting in this one study into multiple research settings, research studies, and hopefully into the clinic. So I think it really is important. And to address this particular issue that I began to realize was actually a big problem as I stepped back from the study a little bit, in the realm of text message work, I began pursuing a project through mHealth, and that sort of answers the question earlier about how we can actually make this low cost. So as far as text message automated customized solutions today, there still is a barrier for clinicians and researchers to build custom automated programs at a low cost with flexibility and without programming. So I think as far as within the text message realm of solutions, of mobile health solutions, I think the approach would be to begin to standardize a platform, one that clinicians can actually use without having to program, and then we'd be able to more rapidly be able to accelerate the science here to be able to do richer formative research prior to developing our interventions and running these trials. So that's sort of my thoughts there.
From the studies that we've done, we looked at predictors of weight loss, and we found that with Twitter, engagement was a huge predictor of weight loss. So if they engaged with Twitter, they lost more weight. And again, with self-monitoring, it was the same thing. If they self-monitored, they lost more weight. So the two areas that I'm really interested in exploring are finding ways that we can get people to engage with those, and how can we do that through incentivizing. We have a grant under review right now looking at the use of intelligent social agents to help really build these social networks that are a little bit smarter, that learn from the interactions of people and then make personalized recommendations to you, and also finding ways to make self-monitoring easier to do and receiving real-time feedback based on that. So those are the two areas that I think are really necessary to move behavioral weight loss research interventions forward.
Do you have questions? Anybody have any questions for the speakers? Go ahead.
In the study with the iPod, did you purchase those iPods and give them to the students?
Yes.
Did you have any problems with loss or damage?
We did, but not as much as we thought. So about 10% of the devices were lost or damaged. We did have a couple of things that we did put in place to try and minimize that. So we had installed a tracker, and we were able to remotely identify and wipe any data. Most participants, the damage was siblings who stole it because they wanted one, or things. It was in my purse, and I dropped my purse. But we actually didn't have that much loss. It was mostly damage. Yeah.
Other questions? Well, thank you all. This has been really a very interesting session.